In an implant-based method of breast reconstruction, almost all of my patients are undergoing they're undergoing two different reconstructive procedures at a minimum. At the time of the mastectomy, they undergo a placement of a tissue expander, and then 3 to 4 to 5 months later, the tissue expander is removed and replaced by an implant. A tissue expander is like an empty implant, and at the time of the mastectomy, that tissue expander is wrapped by an acellular dermal matrix sheet, which is a cadaveric collagen sheet, and is stuck underneath the skin that was left behind after the mastectomy on top of the chest wall. This is done in a prepectoral method for most of my patients, and there's a separate video segment that discusses this. Then the skin is allowed to heal. The patients come back to the office, and during some of those postoperative visits, the tissue expander is slowly filled with saline or salt water until it recaptures all of the volume in the space that was removed at the time of this mastectomy. Then the skin is allowed to heal even more, and ultimately at a time frame of 3 to 4 to 5 months later, the tissue expander is removed and an implant is placed. Often at the time of the implant placement, a fat grafting procedure is done as well, and I discuss that in a separate video segment. I'm sure that some of you in some of your research have learned about a one-step or direct-to-implant method of breast reconstruction. I will do that, but very infrequently, and I think the indications for it are relatively limited. I perform most frequently and prefer a two-step method of breast reconstruction because I believe that it allows us to have the safest process, safer results with decreased complications, and it allows us to perform the most attractive breast reconstructions. Again, the two steps in a two-step breast reconstruction are the immediate phase, which is the placement of the tissue expander at the time of the mastectomy, and then the secondary phase, which is removal of the tissue expander, placement of the implant, and fat grafting when indicated. If women have a skin-sparing mastectomy, i.e. their nipple is removed at the time of the mastectomy, and they decide that they want to have a nipple reconstructed, that actually requires a third procedure, often 3 months after placing the implant, after removing the tissue expander and placing the implant. The reason that in a tissue expander, or rather an implant-based breast reconstruction, I prefer the two-step process is that most people report higher rates of seromas, and I personally have observed decreased quality of results in my particular practice when I've gone direct to implant. Another reason that I don't like to go direct to implant is that the whole benefit of a tissue expander is that when you place a tissue expander underneath the skin at the time of the mastectomy, you don't need to fill the tissue expander all the way. In fact, you can, in a very strategic way, have that tissue expander be partially filled. The benefit of that is that you don't have something large, big, pushing on the skin that has undergone the mastectomy. Why is that important? The reason that's important is that when someone undergoes a mastectomy, a lot of the blood flow has been reduced to the mastectomy skin. And if we place something large, big behind it, pushing out on that skin, we challenge that skin from a blood flow perspective, and we may lead to death of the skin. Whereas when we place a tissue expander, we're able to keep that tissue expander totally empty or partially filled, half filled, 2/3 filled in a very strategic way so as not to put a lot of pressure on the skin, thus allow the skin to have all the advantages of the remaining blood flow, heal, and then later come back in the office, fill that tissue expander and recapture that space with the expansion process, later replace the tissue expander with the implant. If we place an implant in immediately, at the time of the mastectomy, there's a lot of pressure on the skin, and there can be significant complications such as death of the skin and exposure of the implant.